Good evening, everybody. We welcome everybody to this lecture on schizophrenia. To get another seat. So, we're going to be having a lecture on schizophrenia. My name is Dr. Lisa Uche. I'm a consultant psychiatrist at Federal Neuropsychiatric Hospital Enugu and an adjunct lecturer in this department. You're 500 level students, right? Is this first semester or second semester? Is it first semester or second semester? You don't do semester. Why now? Medical students don't do semester. No problem. Not minding the number that we have, we are definitely going to start the lecture because it's not my fault. Or is it my fault? It's not my fault. The material was given to you people and you were supposed to go through to find out when you're supposed to have lectures. We're going to start the lecture. Then after the lecture, I'm going to give out a note so that those people that did not take part would have the opportunity of going through. As I said before, schizophrenia, in fact, we are going to make it interactive. I'm going to be asking you some questions as we go on. So, I know that even before now, some of us must have heard the term schizophrenia, true or false. Schizophrenia. In fact, that is what is used to characterize most severe mental conditions. Like you see somebody walking disabled, aggressive, the first thing that comes to your mind is a severe mental health condition, which the most important of them is schizophrenia. We can say that schizophrenia is a psychotic disorder. We cannot define schizophrenia without defining what psychosis is, because schizophrenia is a subset of a psychotic disorder. So, and psychosis is defined as a state or a psychological state in which an individual has lost touch with reality. Loss of touch with reality is the simplest way of defining psychosis. When you say somebody has lost touch with reality, what does that mean? It means that, is it? Lost touch with reality. When you say somebody has lost touch with reality, what does it mean? Literally means that the person is not in this present world or this present reality. The person appears to be in another world, appears to be in another reality, appears to understand things differently, appears to see things differently. At times, some people have altered perception. They perceive things that other people don't perceive. They hear things that other people don't hear. They see things that other people don't see. They have sensations that other people don't have. That is loss of touch with reality. And again, it's not just about perception. It can also involve thought processes where an individual begins to think in a different way. The person thinks is different from the way normal people do. The way the person understands things is different from the way normal people do. That's a description of loss of touch with reality. I don't know whether I'm clear. We are still defining psychosis. We say we cannot define schizophrenia if we don't define psychosis. Psychosis is a state, a psychological state, or a state of the mind, or a state of being where an individual loses touch with reality. And I was trying to explain it in a way that you will understand it. That somebody has a peculiar way of perceiving things or understanding things. And now, psychosis is characterized by, one, disorder of thought process. There's a problem with the way the person thinks, and that can give rise to what we call delusion. Is one important symptom of psychosis. Before we go in depth into the symptoms of psychosis, we can now define schizophrenia is one of the most severe forms of disorders, or is one of the most severe forms of mental disorders that is characterized by delusions, hallucinations, disorganized thinking, disorganized behavior, and negative symptoms. Some people will also define schizophrenia as a disorder, a severe form of mental disorder that is associated with disorganization of thought process and emotional regulation, which is associated with significant level of dysfunction to the individual suffering it. Any questions? We started by defining psychosis. We said that psychosis simply means a state in which an individual loses touch with reality, which is manifested by the things I've mentioned. Then I will now say that schizophrenia is a form, in fact, it's the most important form of psychosis. And some people have also defined schizophrenia as a severe form of mental disorder where there is disintegration of thinking and emotional processes, or thinking processes and emotional regulation. Some people have also defined schizophrenia as a split mind. Have you heard about that thing before? That there is splitting of the mind. Mental processes are supposed to work in unison. Your thinking processes, your emotional processes, they are supposed to be coordinated. They are not supposed to be disintegrated. You're supposed to, as somebody who has a normal thinking process, you're supposed to perceive stimuli or understand information, integrate information, and be able to make out a coherent meaning from the information. But when these processes are distorted, when they are disjointed, when they are disintegrated, you see that an individual is not able to make out meaning, coherent meaning from the stimuli from the environment. We'll stop at that for now. And we said that schizophrenia is characterized by, and by extension psychosis, is characterized by 1, delusions, hallucinations, disorganized speech, disorganized behavior, negative symptoms, even catatonic symptoms, depending on the symptom domain that the particular sufferer is manifesting, because there are symptom domains in schizophrenia. I think we have to talk about that. It would help us to understand what schizophrenia is. Not just, some people see it as a heterogeneous disorder. I don't know whether people have heard this term in Igbo. Have you heard about it? And that people that made that comment, they are very correct. It's a heterogeneous. It's not like, okay, maybe hypertension now. You know, you can understand what hypertension, you can understand the symptoms, everything ties together. But it's not like that in schizophrenia. And that's why initially they used to classify schizophrenia into paranoid schizophrenia, hebephrenic schizophrenia, catatonic. I don't know whether you've read some tests that classify schizophrenia. Why did they do that? Because the entity called schizophrenia is actually heterogeneous, and each domain presents in a different way. That is why it's good for us to look at the symptom domains of schizophrenia. It will help us to conceptualize what schizophrenia is all about. The first symptom domain of schizophrenia is what we call positive symptoms. Now, positive symptoms, what they mean literally is where you have addition of some behavioral attributes, behaviors that a normal individual is not supposed to exhibit, and somebody who has schizophrenia is exhibiting them. So additional behaviors, that's positive symptoms. And examples are delusions and hallucinations. What are delusions? I don't know whether they have taught you symptomatology of mental health issues, symptoms of mental health issues. What did they teach you in the first lecture? What did they teach you? In basic psychopathology, you're supposed to talk about symptoms now. So, now, what is a delusion? Can somebody define a delusion for me? Delusion is an English word. Even before we started talking about psychiatry, you must have heard a term called delusion. What is delusion? A delusion is a false, fixed, unshakable belief strongly held by an individual despite evidence to the contrary, and which is not in keeping with the person's background. And this background could be social background, cultural background, economic background, religious background. So before you say that something is a delusion, subject that belief system to all these contexts. I give you a typical example. If you go to our villages and meet our elderly parents and grandparents, there are certain beliefs that they might hold based on their cultural inclination, based on their religious, that are not necessarily correct, right? But you can understand why they hold that belief. Probably because of the fact that they are not as educated as we are, they are not as outgoing as we are, and so many other things. It is not enough to say that anything that is not true is fixed, is unshakable. Do you understand? For you to call it a delusion, you must subject that to the person's context. Delusion is a cardinal feature of schizophrenia, and is a positive symptom. It is a positive symptom. You know, we're talking about positive symptom. Now, you also have hallucinations.
But this delusion makes sense.
The delusion is anything that is false, it is fixed, it is unshakable, it is strongly held despite evidence that it is not true, and which is not in keeping with it. You understand? It can be any belief system. but you must subject it to the person's context. Do you understand? Otherwise, it means that when you hold a false belief, now, I know that there are so many false beliefs that we hold now based on inadequate grounds, based on the fact that we don't know. Like that there's an area now we think we know something. But even in health, there are so many people that have a lot of assumptions of what constitutes good health-seeking behavior or not. But those things are not true. But they hold those beliefs strongly, but they are not true. Do you understand? You can understand the fact that maybe because the person is not exposed, maybe because the person doesn't know this thing well, so it's not a illusion. This person holds it, and there is no reason why this person should hold this belief based on the person's exposure, based on the person's religion, for instance, now somebody just wakes up one morning, a young guy wakes up one morning and starts to threaten the mother that he's going to kill the mother. Don't kill me, I'll kill you. But the one that is responsible for my failures, a mother. And surprisingly, these kind of things happen in mental illness. You see that somebody who ordinarily is supposed to be very close to them suddenly comes to their greatest enemy. Do you understand? You see that there is, you are like, this is your mom that's carried you in 9 months, and you try to. Because for you to call something a delusion, you must subject, you must shake it, you must profile an alternative. What if it's this? Okay, even if your mom shouted on you, even if you used bad words on you, could it be that it was because she was angry at you? So you try to give the person alternative explanations, but the person still holds on fixedly and says, no, this person hates me. Do you understand? That is what makes it a symptom of mental illness. That's a cardinal picture of schizophrenia and by extension psychosis. Now the other one is hallucination. Hallucination simply means perception in absence of stimulus. When somebody perceives something in absence of stimulus. Somebody tells you, I'm hearing voices, I'm hearing this person talking to me, I'm hearing the voices of enemies, they want to kill me. And you're in the same space with the person and you're not hearing the same thing. Do you understand? That is hallucination. Perception in absence of real stimulus. And the commonest type of hallucination that you find in schizophrenia is what we call third person auditory hallucinations. Third person auditory. We'll still come to we're still talking about positive symptoms. Now, we can also have agitation, aggressive behavior. Remember we said positive symptoms are additional behavioral attributes that a normal person is not supposed to have. Whereas somebody who has disorder is having. So that's positive symptom domain. You have negative symptom domain. In negative symptom domain, these are behavioral deficits, subtraction from normal behavioral attributes or dispositions. For example, somebody who a normal person is supposed to interact well, have friends, do you understand? Try to interact with people. Try to show emotional reactivity. For instance, if I say something that is supposed to make you laugh, that's a normal person. But for somebody who has schizophrenia with predominance of negative symptoms, the person is aloof. The person is not responsive. The person is not motivated to do what they are supposed to do. So these are negative symptoms, and they can manifest in maybe a decline in occupational functioning. Just like some of you. Well, I'm going to forgive you because you said you didn't know. Assuming this lecture was publicized well, everybody knew about it, and you see that some people will stay back. Why? They don't have the motivation. And it has happened several times. No, for something to be a disorder, it must have happened several times. I'm not just talking about an isolated incident. So you see a medical student, for example, who is supposed to be up and doing, but somewhere, somehow along the line, there is a decline. Things that you want to do before, you will be pushed to do that. You'll be reminded there is no energy, there is withdrawal. You come into the Zoom, everywhere is scattered, it doesn't have the energy to arrange everything the way they are supposed to be. See that these are behavioral deficits. So that is negative symptom domain. Now you also have cognitive symptom domain. So in cognitive symptom domain, because this illness attacks the brain, it's it's a neurocognitive disorder. That's the current understanding of schizophrenia. There are a lot of cognitive processes, mental processes that are not working the way they are supposed to work. And what are the cognitive symptoms? Issues with working memory. Working memory is that part of memory that helps you hold information. Like I'm talking now, your working memory is supposed to be active. You're listening to me, you're picking what I'm saying, you're manipulating the information, you're a kind of trying to compare the information that you're getting against the background, maybe something you've already been taught about, the illness. You're manipulating the information. And again, there's something about working memory. So they say it's supposed to hold 7 to 9 items at a time. And one of the ways of testing working memory is that by pause now I ask you what I said in the last few, or maybe I ask you a question on what I just said, maybe in the last few minutes. If your working memory is effective, you might not be able to remember that. They have issue with working memory. They have issue with processing of information, processing speed. There are some people that when you're explaining something to them, they are looking at you. You think that they are following. But pause and ask them what you just said or to explain. You see that they might not be able to explain that. So they also have issues with attention and working memory. In fact, when working memory and attention, they are tied together. Because for your working memory to be able to give you what you want, you need to be able to pay attention. If you don't pay attention, it means that if I ask you what I just discussed with you in the last 10 minutes, you won't be able to remember that. So they have issues with attention and working memory. These are cognitive symptoms of schizophrenia. And some other. And again, they also have issue with information, processing information. They call it processing speed. Maybe you're telling somebody something, the normal, I'm not talking about a highfalutin thing. Maybe something that somebody is supposed to know. Normal discussion, and the person is looking dazed. Do you understand? The person is taking the person's time to process the information. That's another issue. So we've talked about positive symptom domain, negative symptom domain, cognitive symptom domain. Which other one have we not talked about? They also have disorganization domain, which can manifest in disorganized thinking pattern. And now, the way you speak or the way you talk is a function of the way you think, right? It's a function of the way you think. They also have problems with disorganization. You ask somebody something, have you heard about terms like derailment, circumstantiality, tangentiality? In circumstantiality, somebody asks you something, you're going around, you're not hitting the point. But later on, you might still hit the point. It's a problem of thinking process. Then there's also the one that we call derailment. The person might start from a point that makes sense then and veers off completely. They also have tangentiality. Don't worry, I'm going to give you all these things. So all these things are disorganization domain. Then you also have motor domain. And that is where we classify initially I told you they used to classify schizophrenia. There's a kind of schizophrenia that they used to call catatonic schizophrenia. Have you heard about catatonia? Catatonic schizophrenia, at times somebody might be rigid, motionless. The person might be mute. You're asking the person something and the person is looking at you. Mutism. You can also have what we call negativism. The person is doing the opposite. These things are domains that can be affected. How many domains have we talked about? Let me know the people that have full working memory. Don't look at your notes. The man at the back mentioned one. You don't know. We have an issue with working memory. Where is your mind? Another thing that can affect working memory is distraction. Maybe you're fatigued. You're not justified. Are you fatigued? I beg. Who will bear him out? Okay? Domain. Example of positive symptom domain symptoms.
Hallucinations.
Hallucinations and what? And what? So we are saying that there are additional behavioral attributes that are not supposed to be there. Then which other symptom domain? The second one, negative symptom domain. What are the symptoms? Negative symptom domain. Emotionally cold. Decline in functioning. Decline in occupational functioning. Decline in hygiene. You understand? These are deficits. Social withdrawal. The person is withdrawn from others. Somebody who used to be interactive now withdraws and is not. These are negative symptom domains. Then which other domain? Cognitive symptom domain. That cognitive symptom, what are the things that are there? Attention, processing information, processing speed reduced. So that's motor symptom domain. Another motor symptom domain. You have catatonia. Catatonia is about issues with behavioral and motor responsiveness. Somebody is talking to you or asking you a question, you're supposed to respond. But when you don't respond, you see some people who are mentally sick, you are talking to them, they don't respond. That's mutism. Then you also have what we call stupor. The person is awake. The person does not have altered consciousness, but the person appears motionless. That is stupor. There is also negativism. You have a question? You can also, you have total mutism, you have selective mutism. Some are like children can exhibit selective mutism. For instance, if they are in an unfamiliar environment or they don't know you, they might keep mute. There's a reason for that. But there are some schizophrenia types or presentations that manifest in mutism. They are mute, they are motionless, they are negativistic. In stupor, an individual is conscious, but motion appears as if he is not conscious. Motionless, that's stupor. It's not moving, but the person is conscious. Let's not go deep into all those things. So these are the domains. Which other domain? This organization domain. So we'll stop at that. At least this will now help us understand and socialize more the term schizophrenia. You can see that it's very diverse. And that is why some people have defined it as a heterogeneous group of disorders. And in fact, some people have, by the time we go into the genetics, you see that some researchers have mapped certain genetic abnormalities to specific symptom domains. Do you understand? In other words, the genetic abnormalities that explain, for instance, positive symptom domain might be different from the genetic abnormalities that explain negative symptom domains. Do you understand? And that is why response to treatment may actually differ. And in reality, that's the truth. All these symptom domains, they have a lot to do with treatment response and prognosis. You see, like people who have more of positive symptom domain, fall faster. All those ones that are agitated, destroying things, having hallucinations, once they are brought to the hospital early, they respond very fast. Unlike the ones that have cognitive symptom domains and negative symptom, even disorganization. All these things, they have import. You can indeed see that schizophrenia is a heterogeneous group of disorders. Now, having talked about that, let's go into the etiology. Because of time, we might not go into the historical perspective, but I'm going to give that out in the note. Under etiology or etiopathogenesis, you can say, and that's what I'm going to say now holds true for most mental health conditions and even general medical conditions. So you have an interaction between the gene and the environment. We call it nature-nurture interaction. There is no one single thing that causes schizophrenia. So it's a combination of factors, and these factors are from the genetic predispositions, the genetic environment of the individual, and also the environment, the physical environment. Let's now go to the genetics. Let's go to the genetics. So do we know what is called single gene disorders? What are single gene? Give me an example of single gene disorder. Do you understand? That is a single gene. You know the particular gene, the mutation, where you have substitution of what? That is the problem. That is a single gene disorder. But for most psychiatric conditions, even hypertension and diabetes and other medical conditions, the genetic explanation is polygenic. You have a lot of genes. We call them single nucleotide polymorphisms. Have you heard about that term? Single SNPs and CMVs. Have you heard about? So it's very important. There is no one single gene that independently increases the chance of. No, what we are talking about, I'm explaining. What I'm talking about is that there are so many genes of small effect sizes that when put together increase the chance of schizophrenia. That is the concept of single nucleotide polymorphism in the genetics of mental health issues. So they are saying that it's not just one gene, and these genes are called candidate genes. We have candidate genes for schizophrenia, candidate genes for depression, candidate genes for bipolar and all that. There are candidate genes for schizophrenia, and these genes are many. There are small variations in the structure of nucleotides that if you begin to compare their effects, individual effects, they don't have effects individually. But when you put them together, the effect size of predisposing to schizophrenia increases. That is the concept of single nucleotide polymorphism, and we call them candidate genes for schizophrenia. Some have been extensively studied. And now, what are the functions of these genes are involved in one, production of neurotransmitters, production of receptors, production of molecules that reabsorb neurotransmitters back to the nerve terminals. Any of these things can be affected. And now, let's even go down to the basics. When we talk about, what do you understand by genetic polymorphism? I hope people did that genetics in your clinicals. Have you heard about codons? What are codons? You have what? Nucleotides that code for a protein. Now, I want to use it to explain the concept of single nucleotide polymorphism. So you know that in genetics, there is something they call degeneracy of code. True or false? What does it mean? Degeneracy of code. In degeneracy of code, it means that more than one codon can code for an amino acid. Do you understand? For instance, you have C, U, G, A, B, all those stuff. Two can code. Do you understand? Even if there is a mistake in one, do you understand? Another one can still code it. But the problem is that if there is a substitution or a deletion and a base is substituted, maybe what are the bases that you have? You have purines and pyrimidates. Do you understand? You have, assuming now in a codon, you're supposed to have CU and you end up having CU or A. You see that is a substitution. That's a polymorph. Do you understand? It's not, there is a minor change. Now, the consequence can be significant or not significant. It can be not significant if that substitution results in another alternative codon that codes for that amino acid. There won't be any problem. But if that change, substitution, gives rise to another codon that codes for a different amino acid, there's going to be a problem. Now, but that problem might be minor. It might not be detected here. But by the time we said that the problem can be from the neurotransmitters, that's the genes that code for neurotransmitters, the genes that code for receptors, the genes that code for reuptake mechanism, the molecules responsible for reuptake. Now, if there is this single change, it might not be too significant. There might be some other amino acids that do a similar thing. But by the time, even if it's not too significant, by the time you have this kind of change in several other codons, do you understand? Individually, they might not have before, but by the time you pull the effect together, it causes a problem. There is going to be a change in the gene product, which is protein. That's the concept of, I'm going to ask this thing in the exam. That's the concept of, those changes are not too significant individually. But when by the time you coalesce them, there's going to be a predisposition. Then there's also another concept of copy number variation. Have you heard about that thing before? Copy number variation. In copy number variation, we are talking about significant changes in the length of nucleotides. Either you have significant addition of several codons or significant reduction in the number of codons. In effect, you can have shortening of the polypeptide, which is going to result in a dysfunctional protein. The typical example is venocardiofacial syndrome. That has been extensively researched upon, and it increases the risk of schizophrenia. Venocardiofacial syndrome, that's the George syndrome. You know about the George syndrome? Yes. Where you have microdeletion of the short arm of chromosome 22. That is what it increases. In fact, it increases the risk of schizophrenia for up to 60%. We are talking about single gene effects now. That's copy number variation. So what happens is that the chromosome, you have the long arm, you have the short arm. So if you have a micro deletion of the short arm, that short arm of chromosome 22 has a lot of what's it called, nucleotides. Do you understand? A lot of nucleotides. So if there is a micro deletion, you will see that a lot of gene products from those polypeptides will be dysfunctional. They will be significantly short. And that is why once anybody has that defect, the chance of schizophrenia is increased, significantly increased. Let me just summarize it. We are still talking about the genesis of schizophrenia. And we said that the genesis of schizophrenia is of multiple genes. That's like if you talk about the heritability of schizophrenia. Do you know what heritability is? What is heritability? No, it's not. Now, heritability is the percentage contribution of genes in a phenotype. Just like we said, that in the etiology of schizophrenia, that you have genetic and environmental factors. So in the phenotype of schizophrenia, what is the percentage contribution of genes in the phenotype? That is heritability. It's not the way you're thinking about it. In genetics, that's what genetic heritability. That genetic heritability of schizophrenia is 80%. Is also an MCQ question. When we are talking about the genetic contribution in the phenotype of schizophrenia, we can say that 70% can be explained by SNPs. 70 to 80% can be explained by SNPs, whereas the rest can be explained by what? CMVs. Does it make sense? When we're talking about the genetics of schizophrenia, we are more interested in the candidate genes, and these candidate genes are genes of little effect. However, in the genetics of schizophrenia, there is also a role of single nucleotide polymorphism, where you have macro deletions now of genes. Micro deletions of genes, but it might appear as micro deletion of chromosome. Do you understand? In a chromosome, there are so many genes. Micro deletion of that chromosome is actually a macro deletion of genes because there are a lot of genes there. Do you understand? In effect, it will result in shortening of gene or excessive lengthening of gene. Meaning the gene product is going to be dysfunctional. If it's amino acid, it's going to, if it's protein for receptor, is going to have an issue. So that is the genetics of schizophrenia. Yes.
What's the
Copy number. Yes, we are saying that in genetics of schizophrenia, that the commoner thing we have is SNPs. Do you understand? That is the commoner one. But however, there are, and that's what we call CMVs, rare variants. Have you heard about that before? When you go ahead, they call them rare variants. They don't happen. All these very, how many times have you seen them? Are rare now? Very just syndrome. Have you seen them? Have you seen it before? That's why they are called rare variants. They are rare. They are not common. But when they happen, they significantly increase the risk of schizophrenia. Do you understand? That's genetics. Now, of course, environmental. The environmental factors. Please ask your question. I said, I gave an example of CMV, and I said when you have micro deletion of short arm of chromosome 22, increases the risk of velocranial syndrome, which is the Jones syndrome. Do you understand? Now, I said why I said micro deletion of genes is that in a chromosome, that micro thing that you're seeing, there are so many genes. That's why it will lead to loss of several. Do you understand? It's about understanding it.
I don't really understand. SNPs, we are talking about how different individual genes can cause. More changes in genes can coalesce together. It's not individual one. That's the difference between CMV. But CMV, if that one happens, it leads to schizophrenia, as in it leads to significantly increasing the risk. As that's the way you consider that effect alone. But for CMVs, those little changes, individually, they don't amount to anything. But when they coalesce, when there are so many, just like there are so many thousands of candidate genes, there are genes of individual small effect sizes.
together? Now we can use it.
What I'm asking is that we were saying something after you talked about
Heritability.
Then I went to explain, you're talking about the individual.
I said in the genetics of schizophrenia, I said that the heritability of schizophrenia is around 80%. Do you understand? That is the genetic contribution to the phenotype of schizophrenia, what you're seeing in schizophrenia. But I now said that in that 80%, that SNPs are more, maybe up to 80 to 90%, whereas CMVs are the rest, because CMVs are rare variants. And SNPs are common variants. That's another name. Another name for SNPs are common variants, whereas CNPs are rare variants. They are rare, but when they happen, they cause significant problems. So, and that's why I'm saying that when you're talking about the genetics, we are talking more of SNPs, because SNPs are common. Do you understand it now? That's that. Now, when you now talk about the environmental contribution, you can start from in utero. Prenatal factors, natal factors, and postnatal factors. In prenatal factors, you talk about Touchy syndrome. Have you heard about Touchy syndrome? Prenatal maternal infection can, by effect, get to the baby and harm the baby, because at that particular point in time, the brain of the baby is fragile. So maternal infections, febrile illnesses, maternal anemia, and general health of the mother can affect the development of the brain in utero. So all these things can produce environmental factors, prenatal. Now, natal, you're talking about obstructed labor, prolonged labor, preeclampsia, all those things, diabetes in pregnancy, all those things that affect the. We're talking about natal now. Natal is about what happens at the time. So we are mixing it up. So under prenatal, you have maternal infections, maternal diabetes, maternal hypertension, preeclampsia, all those things that impair the health of the mother. By extension, will definitely affect the baby. And we know that fetal brain is very fragile, and anything that happens to the mother can, by extension, affect the fetal brain development. Then under natal, you're talking about events surrounding the delivery, where you talk about obstructed labor, prolonged labor, instrumental labor, fetal asphyxia. Do you understand? All those things are natal factors. Then other postnatal factors, postnatal infections, jaundice, connectirus, seizures, febrile seizures. Do you understand? All those things can also affect the baby and predispose to the chances of schizophrenia and by extension other neuropsychiatric conditions. Is that clear? But now it does not mean that anybody that has prenatal, natal and postnatal factor will develop schizophrenia. Do you know why? Because those ones are the environmental contribution. Do you understand? For somebody to develop schizophrenia, there is always a genetic component. So there is an underlying genetic predisposition. If somebody already has an underlying genetic predisposition and those other factors come to play, they now add on the genetic predisposition and the person will now have increased risk of developing. It doesn't mean that anybody that has obstructed labor will give birth to somebody who will have schizophrenia. And the inherent genetic factor plays a role. Is that clear? That is the natural interaction in the causation of schizophrenia and by extension other neuropsychiatric conditions. This is the etiology, genetic etiology. Now, we also have neurotransmitter abnormalities. Very important. And of course, by extension, neurotransmitter abnormalities can also be a secondary effect of the genes. Remember, neurotransmitters are gene products. They are proteins. You understand? And we know, now let's talk about the first neurotransmitter that has a significant role in the pathogenesis of schizophrenia. That is dopamine. It has been found that there is dopamine imbalance in certain areas of the brain. Since dopamine is a gene product, it means that ab initio there might be a genetic abnormality, either from SNPs affecting genes that code for neurotransmitters, or genes that code for receptors, or genes that code for reuptake proteins. Do you understand? So that's that. In dopamine, there are three theories of dopamine alpha, dopamine causation of schizophrenia. We call them dopamine hypothesis. It's very important, write them down. Dopamine. The first dopamine hypothesis says that there is global increase in dopamine in the central nervous system. That's global hyperdopaminergia. Now, but there's a problem with that theory. The problem with that theory is that the theory could not explain negative symptoms, because in negative symptoms, people that have negative symptoms, they've been found to have low levels of dopamine. Dopamine does a lot of things depending on the area of the brain that it finds itself. In the limbic system, dopamine can explain symptoms of schizophrenia, but in the cortical system, dopamine is needed for attention and concentration for high order cognitive function. The problem with the first dopaminergic theory is that it could not explain negative symptoms. It could only explain positive symptoms. And that was why it was now revised to dopamine 2 hypothesis. In dopamine 2 hypothesis, they are saying that there is a selective increase in dopamine in the limbic system, and again, decrease of dopamine in the mesocortical system. Is it too much? It's not too much. Let's go to in psychiatry. Psychiatry is heavily laden with neurosciences. You cannot understand psychiatry without neurosciences. All those things they taught you in neuroanatomy and neurophysiology, you have to bring them to forth now. Don't think that there's only skills that neurosciences. Without neuroscience, you cannot understand the pathophysiology. And even the reason why we use the drugs that we use. So before we talk about other neurotransmitters, I want you to write down the 4 dopaminergic pathways in the brain. It's very important. 4 dopaminergic pathways in the brain. You need to understand that to be able to understand what is wrong in the pathophysiology of schizophrenia and how they respond in terms of the use of antipsychotics. First of all, we have the mesolimbic pathway. Is a pathway from the ventral tegmental area to what? Did anybody get that? What's it called? Distinction in anatomy here? Any distinction candidate or physiology? Yes. So, is that? Yes. Who is the person? Yes. Why are you sighing? Do you think it's easy to get a distinction? Now, from the ventral tegmental area of the midbrain to the limbic system, and most importantly, nucleus accumbens. The cell bodies are from the ventral tegmental area of the midbrain to the structures of the limbic system. So, and what does dopamine do here? Dopamine is responsible for emotional regulation, motivation. That is what dopamine does. Attachment of importance to things. We call it science. That is one. Now, you also have mesocortical pathway. The mesocortical pathway, dopaminergic transfer, start from the ventral tegmental area to the prefrontal cortex, especially dorsolateral prefrontal cortex, which is the seat of executive function. It is the prefrontal cortex that differentiates you from the lower animal. Are you aware of that? Again, about prefrontal, did you do anatomy at all? Prefrontal cortex is a part of the frontal lobe which is the seat of judgment, the seat of planning, all those higher functions that differentiate you from lower animal. If dopamine is important in that pathway, what does it show us? It shows us that if dopamine is low there, that is why some of these people have, if that pathway is a dysfunction. Now, you also have nigrostriatal pathway, is the pathway from substantial nigra pars compactor to basal ganglia structures. And what does dopamine do there? Movements. These things are very important by the time you start talking about side effect of antipsychotics. The side effect of antipsychotics as a result of blockade of dopamine in this tract. You see the reason why we are talking about them. So now the last one is the tuberoinfundibular pathway. The tuberoinfundibular pathway is from the hypothalamus to the pituitary, to the anterior pituitary gland, from the aqueous nucleus of the hypothalamus to anterior pituitary gland. And what does that pathway do? Milk production. That is the pathway that regulates milk production, and that is why at times, if patients are placed on antipsychotics, they have expressible galacturia. Have you heard about that before? Because the function of dopamine in that tract is to regulate prolactin inhibitor. If it is blocked, by the time you start using antipsychotics, remember when we use antipsychotics, what do we want to do? Primarily, we want to block the dopaminergic transmission in mesolimbic pathway, because mesolimbic pathway is the genesis of psychiatric disorders. We don't want to block it in the cortical pathway. We don't want to block it in nigrostriatal pathway. We don't want to block it in the tuberoinfundibular pathway. But the problem is that these blockades are non-specific. They block dopamine anyway. And that is the genesis of side effects. That is about dopaminergic system. But for the symptoms of schizophrenia, it is as a result of increased dopaminergic transmission or increased levels of dopamine in limbic system. That is mesolimbic pathway. That is why there's a problem in schizophrenia. Because it's the problem that regulates behavior, it's the pathway that regulates behavior, it's the pathway that regulates emotion. Do you understand? So, and there's a problem of behavior in schizophrenia. Do you understand? So, that is dopamine. The first hypothesis says there is global increase of dopamine everywhere, which was faulted because it could not explain negative symptoms. Do you understand? Because dopamine is needed in cortical system. And that was what now gave rise to the second hypothesis, which says that there is selective hyperdopaminergia in the limbic system and hypodopaminergia in the cortical system. No, the second one, we're talking about the second one. You might not bother yourself with the third one. Just know the first and second one so that we don't take it too complex. The first one, they state, and that is why it was a hypothesis. When you propose the hypothesis, it's either true or false. So the first one, they felt that it was as a result. And how did they come about that? When they gave people drugs that increase levels of dopamine, that resulted in psychotic symptoms like Amphetamine increases the synaptic level of dopamine. They say, oh, maybe it's likely that ab initio there was excessive levels of dopamine in the central nervous system. But when they now started to study the symptomatology of schizophrenia, they now thought dopamine is needed in the cortical system. So it could not explain if it was increased. Why do they have negative symptoms and cognitive symptoms? That was why the theory was now revised to dopamine 2 hypothesis, which says that there is selective reduction of the dopamine level in the mesocortical pathway, and there is increase of dopamine in the mesolimbic pathway. Do you understand? Now, apart from dopamine, there is also serotonin is also increased in the brains of people that have, and that is why we use, by the time we go to the psycho, have they taught you psychopharmacology? They teach you psycho, not taught. So that's why, but at least you did pharmacology now. You know about antipsychotics. What it means is that ab initio, there was increase in serotonergic neurotransmission and also dopaminergic neurotransmission. So there's also increased levels of serotonin. Then there's also decreased levels of glutaminergic transmission, glutamate transmission. So there are a lot of neurotransmitter systems that are involved in schizophrenia, but the principal ones are the dopamine and serotonin. Then after that, you now go to glutamate system. And of course, we know in glutamate is the most extensive neurotransmitter system in the central nervous system. Did you do that in neurophysiology? Glutamate is the most extensive excitatory. We have excitatory neurotransmitters and the inhibitory neurotransmitters. So in the brain, glutamate is the most extensive excitatory neurotransmitter system in the central nervous system. And it makes sense that there is no way a disorder will be affecting the brain without affecting glutamate. Studies have shown that there is reduced glutamate neurotransmission in the central nervous system. And how did they arrive at that? When you use in vitro outside the human body, if you use glutamate blockers, NMDA receptors. You know there are a lot of receptors in that system. We have NMDA receptors, we have AMPA receptor, we have kinase and all that. So that NMDA receptor, if you use a drug that blocks it, it results in something that looks like a psychosis. Could you remember drugs that block the NMDA receptors? Ketamine, these are drugs. So in other words, you can induce psychosis when you use some of these drugs. And now ketamine blocks that receptor. What it means by implication is that if you use a substance that blocks dopaminergic neurotransmission and it results in something that looks like schizophrenia, that initial means that there was reduced levels of glutamate neurotransmission. Did you understand that? Is it clear? Yes. It's not clear. We said that glutamate system is the most extensive neurotransmitter system in the central nervous system. And now, how did they come to understand that there was reduced glutamate neurotransmission? They used agents, pharmacological agents, that block one of the receptors of the glutamate system. One of the receptors of the glutamate system is NMDA receptors. Do you understand that? If you use an agent that blocks NMDA receptor and the person starts to have psychotic symptoms, what does it tell you? It means that most likely that people that have schizophrenia have an issue with that receptor system. It's by intuition, it's by you extrapolate. Do you understand? That's another one. Then you also have a GABAergic neurotransmission problem. GABA is the most extensive inhibitory neurotransmitter. There is also an issue with GABA. Some have found reduced, especially in agitation. Now, one thing I want you to understand is that there is no single neurotransmitter system that explains the pathophysiology of schizophrenia, so that I don't get confused. And in most cases, these neurotransmitter systems interact in complex manner. It's not 1 + 1 is 2 because they regulate each other. The GABAergic system might regulate sympathetic system, might regulate dopamine in a complex manner. Do you understand? And the problem is that once there is a disorder in one, the others may also be affected. So the increased levels of serotonin that we find in schizophrenia may actually be compensatory to issues with dopamine. So they interact in complex manner. But among all these, the most extensively researched for are dopamine, serotonin, and most recently glutamate. But the problem is that glutamate agonists do not improve the symptoms of schizophrenia. Do you understand? Drugs that promote glutamate, even the same thing with GABA. Do you understand? But drugs that block dopamine and serotonin improve the symptoms of schizophrenia. What it means is that why I say it's not 1+1. If glutamate is the problem, and you use a drug that increases glutamate, won't it solve the problem? It doesn't solve the problem. It means that these things interact in complex manner. For now, in the neurotransmitter issues, the key are dopamine and serotonin. How many theories of schizophrenia have we talked about? Mention them. So we're talking about, we've discussed serotonin, we've discussed dopamine, we've discussed serotonin, we've discussed glutamate, we've discussed GABA. Now, there are also neurostructural abnormalities in schizophrenia. Neurostructural abnormalities. It has been found that the brains of people who have schizophrenia, some brains of people who have schizophrenia look different from the brains of people who do not have, or when you compare the brains of people who have schizophrenia with the brains of the general population, they look like people who have dementia. Have they taught you dementia? No. So in dementia, usually have enlargement of ventricles, the lateral ventricles, thinning of the gyri. You know what gyri are? All those convolutions of the cortex, they become thinned, meaning that there is reduced. They also have shrinking of the hippocampus. What is the major function of hippocampus? Memory consolidation. And that is also why they have issues with memory. These are some neuropathological changes that you find in brains of people who have, and now, but it's not in every brain of people that have, but people that have these neuropathological changes, they have poorer prognosis. That is about, I've talked about the symptoms of schizophrenia. What else? Now, the diagnostic criteria for schizophrenia. Okay. Dementia patients that exhibit psychiatric problems. Are you hearing it for the first time? It starts from memory loss, but by the time you have, it's a neurodegenerative condition. By the time you continue to have loss of brain mass in other areas of the brain, especially areas that regulate behavior, they behave like they have psychotic symptoms. But as a matter of fact, we have dementia with psychotic symptoms. Do you understand? But what they are different is that the neuronal loss affects more the areas that mediate. Do you understand? Do you understand? And now I said that these changes, these are brain changes, they are not uniform. It's not every patient that has, so it lacks sensitivity. Have you done statistics? It lacks sensitivity. I'm also specific. It lacks sensitivity because it's not everybody that has schizophrenia that you see all those brain changes. It lacks specificity because it's not only in schizophrenia that you have those brain changes. Even in depression, chronic depression, you also have those brain changes. So it's not specific. It helps you to rule in, not to rule out. Do you understand? Now, when we now talk about how to diagnose schizophrenia, usually there have been revisions of diagnostic criteria. We have the ICD system, we have the DSM system. ICD is International Classification of Disease. You have 10th edition, you have 11th edition. Then DSM is Diagnostic and Statistical Manual of Mental Illness. You have the 4th edition, you have the 5th edition. International Classification of Disease. We used to have 10th edition, we now have 11th edition. So it has been revised. But generally, for you to make a diagnosis of schizophrenia, you need at least 2 symptoms, either from persistent hallucinations, persistent disordered speech, or disordered behavior. Do you understand? You need at least 2 symptoms from all these symptom clusters. And the person must have been having these symptoms for a minimum of 1 month for you to make diagnosis of schizophrenia. But if it is less than 1 month, you use a term called acute psychotic disorder. Is that clear? So that's the diagnostic criteria. Psychotic disorder. For 1 month, more than 1 month is schizophrenia. But if these symptoms are less than 1 month, it is acute psychotic disorder. That is about, and again, in most cases you have, why is it a disorder? Why do you call something a disorder, a mental disorder? Yes, it impairs functioning. Can I affect the personal function of the individual? It can affect personal function in terms of taking care of self, taking care of personal hygiene, eating and all that. It can affect interpersonal functioning because by the time they start having those delusions, everybody is their enemy. They might start fighting and all that. It might impair occupational functioning. For instance, in people who have negative symptoms, they have decline in functioning. It might also affect occupational functioning because when they have interpersonal problem issues, maybe in their workplace are fighting with everybody, they can't hold that job, they will lose the job. Then it also affects functioning in broad social context. I've talked about, there are 4 domains of functioning: personal functioning, interpersonal functioning, occupational functioning, stroke academic functioning, as the case may be. Then functioning in broad social context is that who is this person in the society? Is he able to do what others are doing? Do you understand? How does he function in relation to other people? That is why it is a disorder. When the individual the person might not have functioning affectation in all these areas, but some of these areas will be affected. And that is why it's a disorder. Because, and that's, I think there is a DSM system that talks about that functioning problem. It's actually part of the criteria that in most cases that there is a dysfunction. There's something that the person is going to lack, or there's a part of the life of the person that will be affected because of all this. And it makes sense. When somebody is exhibiting many of these, no way in some aspect of the life of the person will not be affected. This is about diagnosis of schizophrenia. Now, we'll talk about the treatment of, before we go to treatment, we'll talk about investigations. How do we investigate? What is the most important thing that you have to rule out before you make a diagnosis of a psychiatric disorder? Who can tell me?
Stress.
What?
Stress.
You have to rule out you have to rule out organicity, because there are organic mental conditions. For instance, somebody who has advanced HIV can have psychosis. Somebody who has dementia can have psychosis. Somebody who has hepatic encephalopathy can have psychosis. Somebody who has renal encephalopathy can have psychosis. Somebody who has alcohol use disorder can have psychosis. Do you understand? The onus is on you to prove the fact that this is a functional psychiatric condition, not organic. Do you understand? And that is why you need to do biological investigations. In fact, there is a paradigm in the treatment of or management of most mental health conditions. We call it biopsychosocial model. Have you heard about it before? Biopsychosocial. And that is why psychiatrists are different. Other general doctors will just look at the bio. A human being is not just biological. Your psyche can affect you, your physical state. Do you understand? Your social environment can affect your health. That is why the care that we give is holistic, biopsychosocial. The investigations that you have to do will have to follow this line, biopsychosocial. The treatment that you have to give will have to follow biopsychosocial. When it comes to management, we'll start with investigation. Of course, the history, you have to take the history would, all the symptoms that we mentioned, you look out for them. Do you understand? That's your history. You do mental state examination. Many of these thought disorders, hallucinations, you assess them. Don't worry, I'll still give you all these things. But after that, you now go to investigation, where you start with biological investigation to rule out organic mental conditions, because there are other organic issues that can give you symptoms that mimic the symptoms of schizophrenia. Even endocrinological issues, hyperthyroidism, Cushing's syndrome. Do you understand? All these hormonal imbalances can also change somebody's mood or behavior. So the idea is for you to rule out all those. You have to start with the most basic full blood counts and differential to check the hematological status of the person and to rule out whether there are infections. Then from there, and one of the reasons why you're doing that is that some of the drugs that you may place the patient on can affect the blood count. Have you heard about clozapine?
Yes.
Did you do clozapine in your pharmacology?
Yes.
What is clozapine notorious for? Agranulocytosis and also carbamazepine. You understand? You need to do some investigations to make sure that the blood picture is fine before you place the patient, and of course to rule out incipient infections. Now, after that, you do liver function test. Why do you want to do liver function test? You want to rule out liver pathology, because the antipsychotics that you're going to give would be metabolized in the liver. Do you understand? Even some benzodiazepines, there are some benzodiazepines that you don't give when there is liver compromise, because there is extensive hepatic metabolism. You do liver function test, then you do, and of course, if it's somebody that has an organic condition and you see that liver enzymes are deranged, that can also explain psychosis. Hepatic encephalopathy can cause changes in behavior. Then you do renal function test, serum electrolytes, urea, and creatinine. Why? Because the drugs are going to be excreted from the kidney. So you want to check the functional status of the kidney. And of course, if it's someone who has an organic issues with the kidney, by the time you do things like urinalysis, you start seeing proteins, you start seeing cast and all that. It shows you that something is wrong. And of course, once the kidney is affected, you have issues with that. Creatinine level will go high, ammonia level will go high. Those things can hit the brain and still give you symptoms of behavioral changes. The reason why you're doing all these things, first of all, to prepare the person to be, because you're going to give medications to make sure that these organs are working well, and to also make sure that part of the problems that the person is having is not contributed by a dysfunction in those organs. Is when we do some of these screens that we even detect some things that we didn't know existed. Do you understand? There are so many people that are walking around, they think that they are healthy, but by the time you start screening them, you see a whole lot of things. Even viral screening, we also do viral screening for them. Hepatitis, HIV. And why is it important? Because we have what we call HIV encephalopathy. Have you heard about it before? HIV encephalopathy, like in stage 4 of AIDS, it can present with psychotic symptoms. If you don't screen the person, you might think that it's a functional psychiatric condition without knowing that it's an organic psychiatric condition. These are the tests that you have to do. Then you can also do abdominal ultrasound, depending. For instance, if somebody has a comorbid alcohol use, some people who have schizophrenia also engage in substance use. They drink excessively and all that. By doing that, you can also check the structural architecture of some of those organs. Then, neuroimaging is also important, especially if you're suspecting organic conditions. Like if you do neuroimaging and maybe the person is suspecting dementia, of course, you're going to see reductions and all that. That's about that. Now, this is biological investigation. Then after that, you talk about psychological investigation. In psychological investigation, you give them some tests to do. There is one that is called PANS and SANS and BPRS and all that. These are mainly used by psychologists to pick out symptom domains of schizophrenia. Then after that, you now do social investigation. There are social factors that we didn't even talk about them. There are social factors that are relevant in the causation of schizophrenia. Now, family history, family dynamics, chaotic family where you have dysfunctional parenting, family where you have chaos, every time quarrel. Do you understand? When you do social investigation, you find out the dynamics of it. And that's even where you're going to pick out family issue of mental illness. If this person was separated from the mother when he was very small, maybe the mother died. You see that childhood trauma can also be a risk factor. From social investigation that you find out, are there things in the social environment that make this person develop this illness at this particular point in time? Now, these social factors can be modifiable and non-modifiable. It's when you now go into treatment, those social factors that you think that contributed to the evolution of the illness, you try to modify them. Is that clear? Yes, now, we now go into treatment proper. The treatment that we give are antipsychotics. We use antipsychotics or dopamine blockers. That is the mainstay of treatment for schizophrenia. And of course, we have first generational psychotics and second generational psychotics. There are certain principles that guide us in terms of knowing which group of drugs to choose. First generational psychotics block dopamine receptors, whereas second generational psychotics block serotonin receptors more and partly dopamine. Now, because of the blockade of dopamine, non-specific, I told you that there is non-specific blockade of dopamine receptors in all those pathways. So if dopamine is blocking ambrostriatal pathway, you're going to have movement-related issues. If it's blocked at tubercular pathway, you're going to have hyperprolactinemia and sexual problems. If it is blocked at mesocortical pathway, you're going to have, that's why at times they are dull. The dullness might not just be from disease, it might be from the treatment. Because the dopamine is blocked. We call it psychomotor retardation. They are not responding fast. Now, the choice of drug will depend on the side effect profile of the drug, the cost of the drug, the nature of the symptomatology. It's very important. Now, if a patient presents to you acutely, psychotic, destroying things, it is recommended that first line should be first generation antipsychotics. You don't go and start giving the person olanzapine. The person will slap you. You need to sedate the person. You need to give tranquilizers, like haloperidol, chlorpromazine. These are typical antipsychotics, and they block dopaminergic receptors. If somebody presents acutely, it is recommended that you use fourth generation antipsychotics. If somebody presents chronically with negative symptoms, the person has been sick for a long time, is not disturbing and just quiet, it is recommended that you, because negative symptoms are more amenable to second generation antipsychotics than fourth generation antipsychotics. Remember that fourth generation antipsychotics block dopamine in the cortical system, so it may worsen negative symptoms. Do you understand what I'm saying? That's why the knowledge of neuroanatomy and neurophysiology is very important. It's not just about giving her or giving this. You need to know how the person is presenting, to know the type of drugs that you use. Drug choice will also depend on cost too. Schizophrenia is a chronic condition. Most of them are life treatment. The problem is that some of the second generation antipsychotics are very expensive. Do you understand? So you have to balance it. If a patient is going to do well on fourth generation antipsychotics, is already doing well on fourth generation antipsychotics, and it's not having side effects, and there's an issue of cost, then it's better you consume with the fourth generation antipsychotics. Although generally, if you check this with it is encouraged that you start with second generation antipsychotics. Why? Because second generation antipsychotics have reduced tendency extrapyramidal side effects. Did they teach you extrapyramidal side effects in psychopharmacology? Yes. So tell me, give me 4 extrapyramidal side effects. It's going to come out to your multiple choice question. Extrapyramidal, we cannot discuss treatment without discussing extrapyramidal side, because these are the things that you have to look out for. Some other person should help him. I want you to start from how they evolve. The first one that evolves is acute dystonia, where they see them, they turn their legs, their eyes go up, they are too rigid, they are not flexible. That's acute dystonia. It usually happens between the first few days of treatment, of starting the treatment, for somebody who is antipsychotic naive, somebody who has not exposed to antipsychotics before. Usually start, but it's not in everybody that it happens, but in most cases, you have various levels of these things. Or maybe somebody has been on a low dose and increase the dose. The person can also have acute dystonia. The leg will be twisting, the body will be rigid, the eyes will be going up and all that. Then after acute dystonia, you have akathisia. Have you heard about akathisia? In akathisia, the person has subjective feeling of restlessness that is manifested as excessive pacing. The person is not, he just has this urge to move. He's moving up and down. That's akathisia. Now the other one is Parkinsonism. That akathisia happens within the first few weeks. Acute dystonia within the first few days. Are you getting it? Then akathisia within the first few weeks. Then neuroleptic. Did you do Parkinson's disease in your neuropathology? Parkinson's disease is different from Parkinson's. Parkinson's disease can give rise to Parkinson's. Is just the syndrome. This disease is coming from neurodegeneration of the substantia nigra pars compacta. It's a neurodegeneration, just like dementia, Alzheimer's disease. But Parkinsonism that is coming from here is from chemical issue. The nerves, the dopaminergic nerves are intact, but their actions are blocked. Remember, you're using dopaminergic blockers. So it's just like antagonism in pharmacology. In antagonism, a particular agent is going to go and block the receptor, where the endogenously produced substance is going to bind. Do you understand? In effect, you're making it look as if that system does not even exist. Because if they are dopaminergic and they cannot bind on receptors, it's useless. The thing is that one is chemical thing that can always be relieved when you stop it. These are so Parkinsonism can happen within the first few months. It doesn't happen in everybody, in those that are predisposed. Then before you now get it, tardive dyskinesia is the last. Tardive, just like it's called, late. Tardive, late dyskinesia, issues with movement. So usually manifest as pugo-oral involuntary movement. Some people describe it as rabbit-like movement. You know the way rabbits does their mouth, just the twitching. It usually happens in people who have been exposed to antipsychotics, typical antipsychotics, for a long period of time. But it doesn't happen in everybody. So there are people that don't go for checkup. That's one of the reasons why we encourage them to be coming for checkup, so that we'll be checking all these things and find out when they are evolving and stop the offending agent. These are extrapyramidal side effects. So you need to know extrapyramidal side effects. You need to know their pathophysiology, and you need to be able to observe them, because these are the things that you observe when you're treating somebody. In the ethical principle of medicine, they say non-maleficence, do no harm. Even if you're giving something, a treatment that is beneficial, do no harm. So as a doctor, you need to be able to understand these side effects, know how to find them out, and intervene as quickly as possible when you note them. That's that. Now, just like I said, first-generation antipsychotics are most likely to give this, especially in antipsychotic naive patients. Whereas second-generation antipsychotics, what do they give? What is the major problem with second-generation antipsychotics? What's the major problem? Metabolic syndrome, increased tendency to weight gain, dyslipidemia, hypertension, impaired glucose tolerance. These are components of metabolic syndrome. We usually test all these things in the psychiatry, because these are the things that will make the patient not comply with treatment. Doctor, since I started taking this medication, I have been getting big. Nobody wants to marry me again. When men see me, they throw away their face. And the patient will stop the drug. Do you understand? What it means is that it will also help you in drug, it will also guide you in placement of this drug. If you see somebody who was ab initio on the big side, the person is on the big side, a bit obese, with hypertension, it means that you shouldn't place the person on most of the second generation antipsychotics like olanzapine, clozapine, quetiapine. These things have increased risk of metabolic syndrome. So you have to turn more to fourth generation antipsychotics if they can tolerate it. These are some of the considerations. It's not just anybody that comes with schizophrenia, I will tell you, no, you just don't know. There are reasons for all these things. That's the treatment. But generally, textbooks will say second generation antipsychotics because of less distressing side effects. Do you understand? Now, that is biological treatment. In the psychological treatment, what do? There is what we call psychoeducation. First, psychoeducation. You need to psychoeducate the patient on the disorder. You need to psychoeducate the family on the disorder, so they will understand, break it down for them and tell them that it's not a death sentence, that it can be managed. That, once the patient is coming for checkup, taking his medications, they lead normal lives. Then you also need to psychoeducate the family. Most importantly, there is something that is called family session. When you admit somebody who has schizophrenia, before you discharge that patient, you must make effort to bring in the family members, to explain to them, because many of them, they hold several beliefs. They say, is what he did that is following him and all that. You try to explain to them that these are like other illnesses, and that these illnesses can be managed. And you also try to reduce what we call highly expressed emotion. Please note it down. Highly expressed emotion is one of the things that you do in social psychological treatment of schizophrenia. What are highly expressed emotions are emotional and behavioral attributes of family members of people who have mental health issues that affects recovery or that impinge negatively on the recovery of this patient. Now, in highly expressed emotion, you can code the factors as heck. One component of highly expressed emotion is hostility. Family members are usually hostile to people who have mental illness. If they don't know what it's all about, if they don't show enough empathy, that's why you see them, they tie them, they lock them and all that. And this makes the illness resistant to treatment. Because there's no way, the illness has a psychological component. Even if you're giving the person the best drugs, and you're treating the person poorly, you're hostile to the person will never recover. Hostility is emotional over-involvement. Every adult believes they are independent, believes they should be able to make decisions concerning them or concerning their lives by themselves. Nobody likes interference, true or false? True. Yeah, in as much as we have friendship, but there's a limit. I should be able to take this from this is by myself. No, this is my. But people who have schizophrenia, that right is mortgaged. Because their family members will always believe, even if you treated them and they're okay, they believe that. They want them, they will call them back. Do you understand? They don't want them to have that full independence, and they don't like it. Emotional involvement. Do you understand? And critical comments. These are the things that you handle in psychosocial treatments. Critical comment. They criticize them. Let's take you back to psychiatry. things like that. Everybody has their own bad parts. There's a thin line between abnormal and abnormal behavior. There's something that somebody will do to you now, the way you explode, they will say, if somebody didn't know what was happening, the person will say, are you sure this person is not mad? Do you understand? If somebody who has been managed for schizophrenia in the past and the person is okay, and they're now inside the person and the person express anger, the first thing they will have, the thing has started. They criticize the person. At times they even believe that the person will never amount. They tell the person bad things. These are the things that you need to find out in the family dynamics. By the time you bring the family members, you see the interaction. Do you understand? And if you find things suggestive of highly expressed emotion, you need to address, you need to be able to explain to them that they have to accept the person that has been managed, they have to support the person, they have to empathize. Because if that's social support, that's emotional support, and that does not augur well the treatment. That is about social treatment. Now we go to prognosis. In prognosis, that's why in your history there are certain things you must highlight. There are good prognosis factors, there are bad prognosis factors. Some of the bad prognosis factors, can somebody and some people help us based on all the things we talked about, the neurobiology and all that, the presentation. What do you think are negative prognostic factors? Okay, which manifest as negative symptoms and cognitive. So those with positive negative symptom and cognitive symptom domains are likely to have negative, likely to have poor prognosis. What else? And yes, family history of mental illness. That one is a marker of genetic load. I've seen families where up to 3 or 4 members of their families have schizophrenia. So it means that the genetic load is very high. And in such cases, you may not even need any extra environmental factor for the person to break down, where you have such high genetic load. Then another one is early onset. In the epidemiology of schizophrenia, we didn't talk about that, but I'll give it to you in the note. Schizophrenia for males is between around, some will tell you 17 years to 23 years. Then for females, 23 years or 25 years to 30 years. Females usually have 2 peaks. Do you know the reason? Because of the protective effect of estrogen. For some unknown reasons, for some complex reasons, estrogen tends to protect against schizophrenia. And that is why the first peak for females is later than males. Usually have the first peak for males is between 15 and 20 years or 23 years. Then, whereas the second peak, first peak for females, 23 to maybe 30 years. Because estrogen protects women. Now, women also have, second peak is usually after menopause or climacteric, when the level of estrogen has dropped. So, if the level of estrogen has dropped, what do you have? That protective effect is lost. And that's when they have second peak. By effect, early presentation. In people who have early presentation, they are more likely to have those structural problems, they are more likely to have genetic load. Do you understand? The genetic load is more likely to be high. And that's why they are presenting early. Then again, the kind of symptoms, okay, now those that have positive symptoms are more likely to respond better. Those that have good family support are more likely to have better prognosis. There are other prognostic factors I'm going to give you in the notes. I think the time is far spent. Now, by conclusion, one of the most important things that you have to look at in the prognosis is people who have schizophrenia are more likely to die earlier than the general population. Do you know why? In fact, their life expectancy is about 20 years lower than the general population. Do you know why? Can some people help us?
Because they are more prone to risky behavior, social isolation.
Another hand of them. What else? First of all, there is high risk of suicide in them. Although that one is common, most of the studies are abroad. Do you know why? That is why in my practice of psychiatry, I don't jettison some of these older classificatory systems. In ICD-10, although we are using ICD-11 now, there are subcategories of schizophrenia, and one of them is post-schizophrenic depression. Is a category of schizophrenia. Now, in post-schizophrenic depression, is a state in which all the symptoms, especially the positive symptoms of schizophrenia, the disturbing symptoms of schizophrenia have cleared, and the person is gaining insight. If that person happens to be a high flyer, somebody who is successful, and now he's recovering from schizophrenia, he's being told the things that he did, the things he spoiled, some behaviors that he exhibited, what do you think will happen? Very depressed. Use yourself as an example. You understand? This person broke down. And now he's being treated, and In fact, I'll give you an experience. One of the places I covered, there is this pattern I noticed that when students, especially nursing students, they come for their post because the training for nurses is actually very rigorous. They compact a lot of things for them to finish within a short period of time. Each time they come for, many of them, when they come for posting, they break down. We've witnessed a situation whereby somebody came for posting with other nursing students and broke down mentally. The person was still treated himself. In my practice, I've seen it happen over 3 or 4 times. The last one I said, please, I want to transfer her out. That is going to affect her. You can imagine, not just that you broke down in the presence of your colleagues or classmates, you're being treated in the same place. Do you understand? By the time you recover from the illness, it's stigma. Do you understand? That's why the concept of post-schizophrenic depression, I think, is still very relevant. Because by the time they finish all those, they are being treated, they are getting well, they are getting insight. They now begin to understand that even the diagnosis alone of having schizophrenia, or the person is being told the bad things that he did, his mistakes and all that, is enough to take the person into depression and suicide. Do you understand? Maybe if you're somebody who has a political ambition, you can't come back again and say, this bad man. Do you understand? That's one of the things that can lead to suicide. Then again, issues with somebody who has mental health problem might not be able to take care of their physical health. Do you understand? They can engage, just like you mentioned, risky behavior. They might not be able to take care of themselves and all that. Then they also have other comorbidities like metabolic syndrome from the treatments. And once we have metabolic syndrome, all this increased BP, dyslipidemia, definitely cardiovascular issues. Ladies and gentlemen, we'll come to the end of it. Any questions? I think the next time we'll have lecture is Wednesday. Can you check now? Please check now and find out when we have the next, so that you won't tell me that you didn't know. Is this right?